Hello and welcome back to SPT with J and Z. I'm Zach Carson,
I'm Jack Griffith.
and we are here to review week 3, 4-ish of our progress in the Grand Valley State University Doctorate of Physical Therapy program. So this week we are progressing pretty quickly. I know that we have our first, we had our first practicals this week in our physical therapy examination, so that was fun. We'll talk a little bit about that here in a little bit. Next week is really when it picks up, when the class starts to get into the anatomy exams. You guys will be working on cadavers, and in the lecture portion, the following week after that just keeps spinning. We're going to have practicals in kinesiology, biomechanics. We're going to have physical therapy exams again after that, and it's just going to keep rolling and rolling and rolling. So this week was pretty good. Everybody made it through. I think we're all still intact. And,
So far, so good.
yeah, I think we're ready to rock. Do you have anything to say on top of that?
No, I think we're ready to roll through it today.
All right. I just want to brush up on where the MLB stands. The Indians, again, 27 to 28 games in a row. They just won't stop winning. I really hope they don't win the World Series, though, because I don't like Cleveland. Neither one of us do.
No,
We're
not
both
really.
AL Central guys, and
Exactly.
they are kind of nemesis in the AL Central. My fantasy team got off to a good start again last night.
Good.
Todd Gurley,
Oh yeah.
he was a beast. I think he scored 37 for me last night, so I'm doing pretty good. Do you have anybody playing last
No,
night?
not last night.
No?
But I did win last week, so that
Nice.
was
All
my
right.
first win of the year. So.
Nice. All right. Well, we're off to a good start there. Aside from that, let's break it down and let's get rolling with our first topic. Josh is going to take that.
All right. So we have our anatomy lecture in our lab this week. We were finishing up and getting ready for our practical on Monday. So we had our last official lecture on Monday. So we went over the hand, the ligaments there, the tendons, carpal tunnel. We really focused on because we've always touched on it, but we've never gone deep in checking out the structures falling underneath it and going into the cartilaginous tissue in there too, because we've done a lot in undergrad with the muscles. And I think that's kind of where it stops. Is like we touch on those structures, and we're really getting, like we've said every week, we're getting in depth, making sure that we know everything of the hand, because it's so intricate and it's so important in our everyday lives that we really need to be able to work with our hands and be able to know what's going on with others. Because carpal tunnel syndrome affects so many people. every
Pop
year.
quiz. What nerve is affected in carpal tunnel syndrome?
Ulnar nerve. I don't know. Whew. I got some
My
more.
man has some work to do this
I
weekend.
told you, I'm about to hit in the lab in like an hour, so don't worry. All right, so one of the other structures we looked at that I have never talked about was the anatomical snuff box, which has the extensor pulsus longus, brevis, and abductor pollicis longus, I think. No?
Oh, that's right.
Okay, we got it. So those are the borders, medial and lateral borders. All right. So then we dove into the lab and got to see the hand on the cadaver, and we have some models that are just plastinates that also help so that we can see more examples. And then Wednesday in lab we just had open time, so I think a lot of us actually got in an early workout to get running, and then hit the lab during our regular scheduled time. Had a practice exam, so Laura was able to go in and tag structures. We didn't look at the bones because I think she's pretty confident in our ability to get over the bones, but we went and looked at the nerves, which everybody is still working on for sure. A lot of the forearm muscles were tagged because there's so much going on in our forearm and hand that I think she really wanted us to look at it.
I heard if you get nervous and you're working out the body, you can grab a nerve from the body and it'll calm you down.
I hope that's true. We're all gonna be grabbing all the nerves in, I think. So
Don't touch the bodies.
yeah, yeah, exactly. I think we can touch the bone, but no other structures in there. So it was a good week of studying. I think everybody's starting to get more confident. Still have those, unsure that we know everything. All of us want to be, proficient in everything. Feel like we have it 100% going in, but reality is there's so much going on that there's going to be a little uncertainty, I think, regardless. So, good week in anatomy. Moving on to kines, which is our next practicals coming up after anatomy. So Zach's going to take it away for our lecture portion.
So just to run it by you real quick, the median nerve is actually compressed by the flexor tendons, right? The ulnar nerve comes down through here on the ulnar canal.
With the ulnar artery.
So, that's actually a clinical correlate that gets talked about a lot because so many people are in that population that end up with carpal tunnel syndrome, whether it be just from sitting at the desk typing with their hands or doing different physical labors where they're getting compression of those tendons, and it's pretty chronic across the population. So rolling into kinesiology and biomechanics for this week, big week in lecture and lab. We're really progressing nicely in that class. The biggest part that we covered this week was lumbar spine kinematics. So we jumped from the thoracic, rolled it straight down to the lumbar spine. Next week we're going to jump up into the cervical spine. So kind of a gap right there, but I think the reason we did that is because we wanted to talk about the thoracic spine, the thorax, the ribs and everything before we talked about things above and below it. So we talked about the anatomy of the lumbar spine, including those intervertebral discs. Obviously you have L1 through L5, the intra and supraspinous ligaments, the anterior longitudinal, posterior longitudinal ligaments, the facet joints and their orientation, how they actually take the orientation from the thoracic, which is more of a frontal plane orientation, and then as they get down to the lumbar, they kind of turn into that sagittal plane orientation, which promotes more degrees of flexion and extension, more so than the thoracic spine. However, it restricts rotation with those facet orientations. So we talked a lot about that. We also talked about anatomical differences, how some facet joints can just be wonky. One will be here and one will be here, and then how everybody's different because, again, everybody's spinal kinematics aren't going to be exactly the same. So we also talked about muscles that resist the shear forces and flexion and extension. So we talked about when you go into flexion, the muscles that resist it, largely the abdominal muscles and some of the other structures there. Obviously, you have the ligaments that are on the spine, and then the facet joints again. When you go into flexion, we have all the erector spinae muscles, metaphysi, all the small muscles back there, anything that attaches to the pelvis. So we covered all those. We went into the osteo and arthrokinematics and talked about how the cranial vertebrae sits on top of, obviously, the caudal vertebrae, and it translates ventrally or caudally on that vertebrae as we go into flexion and extension, and again, how the facet joints have that capsule, and you get those different glides in superior and anterior direction. So we talked again about how we can go caudal and ventral, which I couldn't think of that word last week, and you said superior, which is also acceptable, and then cranial and ventral, and caudal, and see, I'm already losing it again.
So okay, superior. So we have cranial vertebrae sit on top of caudal vertebrae. Cranial is the same as superior, and then the caudal is the same as the inferior.
Yeah, so dorsal and caudal is what I was looking for. So obviously dorsum, like a dorsal fin. Do you have a dorsal fin?
Oh my goodness.
And then ventral, a little ace anterior drop for you. By the way, my life is like largely a composition of sports references and movie references. So if that's what you pick up on, then that's exactly right. All right, so then we also talked about coupling again. The coupling in the thoracic spine, and then obviously everything down through the lumbar spine is gonna deal with coupling. We knocked on the Nordic and osteopathic examples again, and we talked about the Nordic. When you're in the flexed position of that spine, you get a side bend right and a rotation right. Then you have same side coupling. Neutral was side bend right, rotate left, so opposite coupling. And then extension was side bend right, rotate left, opposite coupling also. And then in the osteopathic model, the only thing that changed was the extended was side bend right, rotate right is coupled. So with the coupled versus non-coupled movements, we're talking about quality and quantity of movement that we get out of those sections of spinal segments. And then we also talked about facet gapping, and the gap with the facet joints being sagittal plane oriented. They always gap on the side that you rotate towards. So if you rotate towards your left, that left facet is going to gap, and then the right facet is going to translate into each other. Biomechanical properties of the intervertebral disc, we just talked about the composition real quick. We talked about how you have the annulus fibers around it, and then in the middle you have that soft nucleus pulposus. We talked about the composition being proteoglycans, type 2 collagen, and elastic fibers, and then also that vertebral end plate actually factoring into the entire structure. And we talked a little bit about the annulus fibrosus, how each layer actually runs different directions and really provides that nice solid disc for our spine to move on instead of just moving and herniating on every single movement. So they're really designed beautifully by our creator, and they are kind of the safeguards in our spine. So, and I know that later we'll learn a lot more about disc herniations and bulging and all that, and how we can prevent that. So that'll be more to come later. Moving on to the lab portion, Josh is going to take us over on that.
Okay, so we've done a lot more palpations. You know, we've done a lot of different structures recently, trying to make our hands smart still. We went over a lot of review from the previous week, so I think we had 15 minutes, 20 minutes at the beginning of both labs to practice what we'd done the previous week. And we went over the lumbar spine, did a lot of thoracic. I think a lot of people are still having a difficult time finding those transverse processes. I know I am for sure, compared to the spinous.
Tough.
And then just feeling the fiber orientation for each muscle has been a new experience. It's hard to do with the smaller muscles, but we're able to feel more of the muscle bellies on those bigger ones. We're really able to differentiate there. Electrospinae has been, it's easy to find, longissimus, it's a bigger muscle, but trying to find that spinalis and then ilicostalis is still a challenge, I know for me anyway. I'm still learning, my hands are still kind of dumb right now, so always practicing though, and just kind of trusting my knowledge of where the structure is supposed to be, and that actually is what I'm touching, because it's difficult for the instructors to know exactly what you're feeling. They may know if you're in the correct region, but they may not know if you're actually feeling it. So just learning how to kind of trust what you've learned so far is helpful in knowing what you're on. So we worked on the back quite a bit, and then we went to the abdominal cavity, where it's a little more invasive, I guess. So we talked about making sure the patient is comfortable throughout, making sure we're taking it one step at a time. Communication is key when we're getting into into the pelvic air regions, especially with those of the opposite sex as well.
The visceral organs are a very sensitive area to jump into.
So we went over the rectus abdominis, internal, external obliques, and then we got to the transverse abdominis. It gave us some really good tips and tricks on how to get into the spot that we're supposed to be. And I think it's been good so far as giving us those hints, because you never really know. You don't know when you come into this. This is not a skill that you are just going to pick up. You need every little detail to be able to be effective at it. One of the most invasive, or two of the most invasive, I guess, were the pubic crest.
Yeah.
And then we had to go deep. We got into the diaphragm, feeling up underneath our rib cage. Is uncomfortable for the patient. When we practice on each other, that's helpful, because then we kind of understand what the patient's feeling. And then we got deep to the psoas major, which, oh my goodness, are a few inches deep, touching the spine basically.
Yeah, the psoas major literally lays on the posterior wall of the cavity here, so you have to actually go through those visceral organs, get down basically to the transverse process of the lumbar spine to feel that muscle belly, which is
it was very interesting. It was cool to be able to find it, but you have to be patient. That's the hardest thing, is you can't go in so hard because it's so deep. You just gotta relax and keep the patient relaxed, and eventually you'll get down to that deep layer. Otherwise they're gonna tense up, and all those superficial muscles are gonna kick you out, so you're not gonna be able to make it all the way down there. So do you have a joke for us?
I do. I have a couple things to add. One, just coming off of what you're talking about, is we talked about this before, patient experience and patients being comfortable with what we're doing. The more comfortable they are with you as a person, the more they're going to be able to relax and let you get to those structures and not be so guarded or tense about what you're doing with your hands. So speaking of hands, I just wanted to jump back to you saying that your hands were dumb. And I remember watching this movie as I was a kid about this hand that was like killing people.
Oh
And
gosh.
I don't know if you guys have ever seen this, but it's called The Hand. It's actually from the 1980s, where this guy loses a hand in a car accident and gets severed, but they don't find the hand at the scene of the accident, and it comes back to like haunt
Oh my
them,
goodness.
and it's insane. So if you ever get a chance, check out The Hand, 1981, Oliver Stone, solid director there. So the 80s were a great time for movies. I mean, Schwarzenegger thrived. I mean, anything can be done in the 80s. So come with me if you want to live. I'll just throw that out there. We're gonna roll now into, did you have anything else to add for palpation or anything in Kines Lab?
Just think practicing on so many different bodies, because everybody has different prominent muscles. I know working
Yep.
with females
Yep.
is a lot harder to feel the muscular structures, whereas they're really good for feeling the bony structures. Also, I don't know where I was going with that. Actually, this is a good one. I'm not coming back to it later. I don't know where I was going, but that was, I think, practicing on multiple people, because when we get in the clinic, we're going to be having a new person every hour
Oh, yeah.
or two, and
Yep.
getting to just get our hands familiar with multiple bodies is going to help in the future.
And the professors want us to succeed too. They are more than happy to help verify if we're in the right area. Even if you don't think that you're in the right area, you might be in the right area. Professors are teaching us techniques and giving us verbal cues and just kind of teaching us exactly what we need to do, and letting us know that it's hard for them sometimes too. So that's always re-encouraging when we're working on somebody and we're like, well, I have no idea. So just something to think about. But we're going to roll forward and talk a little bit about our foundations class this week. We had our first week of practicals, and I think everybody did pretty well. What practicals looked like in this class specifically is we did a posture assessment, and we did that on a picture actually. So we had a picture up in class with somebody standing in the anterior, posterior, and then side views, and they had postural defects. We had to identify what kind of posture they presented with. In this case, it was lordosis or lordotic. And then we had to name a couple of postural defects that they had. So off the top of my head, I remember this person had a forward head, so of the midline, their head was kind of forward. The shoulders were pretty good, but they did have like a right lateral shift. It was either right or left, I don't remember. Their shoulders were shifted one way or the other. Their hip was hiked a little bit. So just us being able to recognize the postural defects of a person, not necessarily how to fix it yet. We haven't really gotten that far, but we're just kind of getting our eyes and our hands more comfortable with what we're going to be doing later as we get further into the syllabus and further into the program. So then we had a lifting body mechanics video in which we showed a woman walking up to a table, bending over at the back, throwing some books onto a couch, wiping the table down, and then placing the books back on the table. Basically said, hey, what is one thing this girl did good? What is 3 things this girl did bad? So, bending at the waist, not at the back, kneeling down, being not loading and throwing, so don't twist while you have a load, some different things. And then she kneeled back down nicely as she put the books back, so that was really nice of her after she did everything else wrong.
Mm-hmm.
So then we had our actual hands-on practical. We were partnered up with a random draw, and we got a chance to go in and show a little bit of our skills and what we've learned. So we had to do one anthropometric measurement, we had to take a blood pressure, take a heart rate, and then we had to demonstrate that we were capable of teaching lifting one thing off the ground. So that could have been lifting a suitcase, it could have been lifting a bag of salt, could have been lifting a box full of books, could have been lifting, the one that I did was a golfer's lift.
That's actually what I did too.
Did you?
Yeah.
Nice. I was like, this is after you get a hole in one,
Right.
which I never got, so I've never
Just
had to
mini
execute the golfer lift.
Mini golf.
Yeah, so I went in there, and the first thing she says is, hey, let's take a anthropometric measurement of the figure 8 on the ankle. And I was like, all right, let's start this party off
That's
right.
what I did too.
Was it?
Yeah.
Sounds like we had the same dang practical.
I feel like it.
So I was like, well, let's just get the hardest one out of the way and,
Yeah.
you know, kind of clear it. So that went well for me. And then me and the instructor, we both had the same heart rates and same blood pressures when I measured. So I was pretty confident with that. And then they hit you with 3 verbal questions at the end. And me specifically, I know this is where I lost points overall, is we talked about when you would use a volumeter, and I correctly got that. But then she said, why would you use that over a measurement? And I was like trying to put it together in my head, and I was saying things that made sense to me, but it wasn't coming out in the right like the right words. So I was saying things like, oh, it's like gross damage versus like if you have something specific on the ankle, and what she was looking for is local versus diffuse. So I know I got knocked down for that in the remediation portion. She kind of talked to me about that, and I was like, local or diffuse, exactly. Which makes sense, because if you have a localized inflammation, it would be easy to still make a measurement around the ankle, whereas if you have a whole foot that's swollen, you're not going to be able to get good results unless you take it and do that water displacement with the volumeter. So that was my experience. It went well. I knocked it out of the park. I felt good. My heart rate was not racing like some of the girls in class. Like mine's a steady like 50, which is still pretty low.
Wow.
And
That's good.
my partner was like 92. She was, and her normal heart rate's like 70, 72 or something like that. So she was definitely kind of all over the place. But how was your experience?
Mine was pretty good. I always have a little bit of a test anxiety, as I am now for my practical on Monday. But I was able to channel it. I think a lot of the time, everybody's knowledgeable about what they're doing. It's in these practical situations where it's game-like or it's a lifelike situation. You got to go and execute what you've learned without any outside help. And verbalizing what you're doing, I think, is a lot harder for people than just doing. A lot of people are doers, and trying to explain or answer random questions it makes you think on your feet, which we're going to have to do as a PT. So it's really good practice there too. I came in, did the same. I had the figure 8 measurement, nailed that one, no problem. Then I think I did the golfer's lift, which you just had to explain. She had me explain a couple of principles that I used when I went to bend for it. And so it was like keeping a neutral spine, keeping the plant leg straight for the most part, and looking for a base of support. So I grabbed onto a table nearby, and then grabbing the pencil or pen or something small. It's not a heavy weight, it's really a really light one, and then just standing back up. So it's like if you dropped a notebook or something like that, something to keep your body. You don't have to bend over at the waist like with 2 feet planted on the ground. Is something that's easy for you. So then I went to do my measurements, blood pressure, and the first time I took the blood pressure, we practiced with I practiced with my partner previously, and he'd been around like 110, I think, on his blood pressure for a systolic. So I was like, okay, I'll just do 160 because that's pretty high, and even if he is stressed out, that's probably gonna be plenty. Well, whenever I did it, I released, and pretty much instantaneously I hear boom, like the first sound, and it threw me off. I was like, wow, that was 144. That was high, like high for him. And then I came down to the diastolic, and it was around 60. It was 60, I think. I was like, do you mind if I do that one again? Because I'm not too confident in that first number. So she was like, yeah, you can do that, verify. And I actually was correct. I got 140 over 62 the second time. So it was one of those things where we're going to have white coat. Some patients are going to have white coat syndrome. So even if you overestimate what you're pumping up to, it may still be wrong. And there's nothing wrong with double checking and doing it again. So I think that was something I learned. And it's okay to double check. You don't have to get it the first time. And then pulse was fine. And question wise, I got to systems review. Got a couple questions on like what would be a neuromuscular test for a patient that comes in, and you can just kind of look at their gait as they're walking around, make sure that they're fairly symmetrical. And then I used a test, which was the sit to stand, which I believe you can use for musculoskeletal as well.
Strength also.
So for strength, and it's really to check your fall risk for people. So I used that as my second example. And then the other questions I don't recall, but I didn't think I had any problems with those. So overall, my energy, my I guess, anxiety, or I like to think of it as my excitement, because you respond, however you respond, in a fight or flight situation, you can change it with your mindset. So if you think you're in control of those emotions, those heightened levels of excitement, then you're going to be better off and able to channel it to positive results.
Yeah.
So I think I did that pretty well for the first time, which I was pretty nervous going in, I'm not going to lie. So
I mean, the nerves are always going to exist, but you'll get more and more comfortable. And I wanted to also throw in there, it was funny, I was working with a client on Wednesday night, one of my newer ladies in my adult weightlifting class, and I was doing single leg balance, and you're familiar with single leg balance,
Mhm.
you know, right hand with a weight anywhere from like 3 to 6 pounds, and you're on your right leg, and essentially you're just kind of keeping that knee locked in, and you're bending at the waist, developing that balance through the hip. And I was like demonstrating it for her, and I was trying to cue her on it to teach her, and she goes, "Oh, you mean like a golfer's lift?"
Wow. It's so, I mean,
And
so many things.
I never think about it because I don't ever think like, oh, this is a golfer's lift, because it's just such a natural movement.
Mhm.
But I mean, I guess when you're teaching it or breaking it down, it's nice to put that visual cue on somebody. And she actually put the visual cue on me, and I was like, oh, yes, exactly what I was trying to demonstrate. So thank you for that. So great, yeah, we both had good practical experiences, and we crushed it. So no issues there. It was awesome. I'm looking forward to the next practical experience.
I think they prepared as well. It's
Yeah.
not like we're just like, oh yeah, we're just awesome. No,
Yeah.
we executed what we were instructed and
Mhm.
had confidence in it, and that's what you got to do with PT.
Mm-hmm.
Be confident in what you've learned. Trust the faculty for preparing you, because they know what they're doing. So I think that's awesome.
All right, let's roll forward on to evidence-based practice. And this week in evidence-based practice, we really didn't cover a whole lot. We had, the first thing we had was one of the library representatives came, and she talked about what was available and the resources in the library. And it's actually pretty cool because Grand Valley has a whole resource available on their library webpage. They have like a course reserves and then a database for basically every individual science or department that you could think of, and physical therapy is one of them. So all of the resources kind of isolated onto one tab is really kind of a super cool resource that we have, and a benefit that we have as students at Grand Valley, that they're willing to put in that work and put those things together for us. So a couple of things we did cover was using the library, the why, because the research won't come to you, and you really have to become part of finding the research. Not every day does your inbox or your email fill up with research articles, and I mean, sometimes you might have that, but a lot of times, like for me, I do follow a couple of sites, and I'm like, not interested, and I just delete it anyways. I don't even go into it. So when it comes down to actually like forming a question, searching the evidence, evaluating the evidence, it's important to have those resources. Then we have to go forward and integrate our findings into practice. So once we're actually in the practice, kind of back to that three-headed monster we talked about last week, the client is, the client's values or patient's values, the clinician and their abilities, and then the evidence-based practice. So we have to be able to know where to go to find these resources in order to implement them in our practice. Once we do that, we can evaluate what we have done, if it worked, if it didn't work, how we can mark it, and then how we can move forward, and then just keep repeating that process over and over and over. Questions generally have 4 components. What are the patient details? So like age, gender, diagnosis, the intervention or exposure, what kind of tests and measures we might use on that person. Comparison, so what other tests might be used for the same diagnosis, and can you compare the 2 tests? Do they have any kind of inter-test or reliability? And then the outcomes of what was tested. So a couple of things to think about when we're actually sorting through research, if we want to use that research as a valuable source for our practice going forward. And then again, we just talked a little bit about search engines and what were available for specifically PT, and then obviously just like the science community and all these different resources that we have available. And the biggest thing that we talked about was like, you're not going to find a research that's exactly specific to the person you're working with. There won't be research that exists because n equals 1 when you're working with your patient or your client. And you might be able to find a piece of research that has relatable value to your client, and that's when you take it and see if you can actually use it and apply it. Maybe practice on your client as long as it's safe within the practice, and then go forward and learn from it and then repeat. And that's pretty much all we learned this week. Now we're going to keep going with that, and eventually we'll kind of dive more into writing and researching and hopefully implementing into practice later.
All right, so on to 515, our professional topics class. This is the one that Zach doesn't have either.
Correct. Yeah.
So this week we went into breaking down our ethical situation we had, where we had a PT that was instructed by the manager to have more clients than he could really get to in an hour. The PT was used to having 1 to 2 clients per hour, but the manager was trying to make more money, so he said, we're going to do 3 to 4. You have to see 3 to 4 patients an hour. And we broke down the ethical issue of, are we really being good to our patient? Are we giving them the best treatment possible if we're not there for them for the full hour? Because if you're only getting 15 minutes of good quality time with each patient, that's not what we're in this for as PTs. We're here to make relationships with our clients, get the personal aspect. We want to be there for them for 30 to 50 minutes, whatever we have with them that day. We don't want to have 4 people that we just see briefly. We're in this business to make those connections and to be there, whereas in the medical industry they have to see so many patients. That's really not what we're trying to do here.
Mm-hmm.
So we broke down that and found that it might have been better to be gone from that job. If you're going to stand by your principles and follow the code of ethics that we have for PTs, you're there to make sure the patient's in good hands, not to make an extra buck. That's where what it came down to for the most part. And talking to the owner of the clinic is another route, and talking to the manager, communication. It just comes down to communication. You can't just sit on your hands and be like, oh well, my patients aren't getting what they need, but this is what they said, so I'm just gonna go along with it. No, you have to work for the best situation for everybody in it, and putting the patient at the forefront.
Mm-hmm.
The second day this week was unique. We didn't actually sit in class. We went to the Pew campus and watched a speaker that was from Lima, Peru, where he now works in Houston. I believe he's a professor at Rice University. And he talked about, he's a psychology professor, and he talked about how in the medical industry we have to have a lot of collaboration, a lot of teamwork, because as PTs we're working with MDs. They're referring to us. Now that we're direct access, we're going to have to refer to other people. So he talked about teamwork. So not just teamwork within our own profession, but with other professions. And what's unique at Grand Valley is we're going to be able to collaborate with the Ferris State Pharmacy Program, Michigan State Medical School, and have some collaboration days where we're working with them in real life situations, which I'm pretty excited about. He really broke it down to where teamwork is a lot about cooperation, communication, and coaching. So we're coaching our clients, we're coaching our peers, we're communicating constantly. We have to, otherwise we're going to have some issues and patients aren't going to get what they need. He also talked about the ideal team is one that doesn't have to always communicate verbally. You know your role, you know your job, you know what you have to do. He made it into like a sports term. So when you think of basketball, the best plays aren't guys talking. It's a guy making a backdoor cut to the basket, and his teammate just sees it and he just reacts. It's just a reaction, and they feed off of each other. So his example of a real life situation, besides sports, was he went to a high-end restaurant. In the kitchen, all the chefs never talked to each other once. They just moved around, and once they got the order, they just moved and had fantastic meals. It was just they knew their role, and they executed their role, and they had trust in each other. But then whenever there was a new order, they would collaborate and say, okay, we don't know what this is. What do we need to do? And so the communication where you come together and you have to tackle a difficult role, but then you just go off and do your role. And you just have to meet up every now and then to figure out what do we have to do to tackle this problem, this issue, and then you go and do your role. So I think that was pretty cool because those are things that we're supposed to do, and you know you're supposed to do it, but it doesn't happen all the time. So it was a good reminder that that's where we're going to be headed in our profession and working with others. So
Okay. I was trying to get Josh to laugh by pulling up a meme of The Rock saying, "Know your role and shut your mouth." Obviously, that's not exactly how it works.
no, no.
But it's the first thing that came to my mind, and it was funny. Actually, our professor made a reference to the people's elbow this week. Do you remember that?
Yeah.
Did you know what he was talking about at the time?
No. I don't watch WWE. I mean.
Yeah, I used to be a big wrestling fan. I understood that it wasn't real, so it was just fun. And my buddies and I would actually be out on the trampoline, like doing power bombs and stuff and slamming each other. It was really dangerous. But I'm here. I survived. I don't have any significant injuries. I feel like there was something I was going to say about that, since I didn't get a chance to see it. That was a good breakdown of the speaker. And you mentioned when they didn't know what they were doing, they would stop and they'd talk about it and
debrief.
And that's a big part of communication that a lot of professionals, especially professionals that have been in the field for a long time, have trouble kind of swallowing their pride and being like, I don't know what I need to do in this situation. So hit stop button, collaborate, cooperate, communicate, and then go forward with a good plan instead of just trying to figure it out as you go, because that could lead to, possibly some kind of injury or something along those lines. All right, so let's jump into clinical science for the week. This will be our last topic. I'll jump on the first portion. Josh will wrap us up and bring us home today. So we walked a little bit down the path of environmental and occupational medicine in this class. So we talked about those things, and obviously they're a big deal. Environmental medicine essentially encompasses industrial and occupational, the industrial portion, and then occupational medicine is environmentally induced illness and conditions. So why is this important to the PT? Because we're going to be dealing with these things in the clinic. I think one of the most significant things that we talked about is latex, and people having a hypersensitivity reaction to latex, and why it's important. Because if we don't know that our client or our patient is allergic to latex and we use it on them, that's going to be a big no-no. But a few numbers to throw by you guys. Occupational medicine is a specialty involving the health of workers in workplaces. 140 million U.S. workers sustain on-the-job injuries annually. So that's a big deal. That's lots and lots of money. Specifically, direct and indirect cost of $170 billion a year. Billion with a B, not million. And why is it important to PTs? Because PTs treat these conditions: sprains, strains, avulsions, amputations, overuse of cumulative trauma to disorders. So, especially with these different industries and kind of like their laborious jobs where they're doing a lot of bending, and this is where a lot of low back injuries come from, they end up with strains and sprains, and they need to see a PT or some kind of rehabilitation specialist. A lot of times it simply comes down to ergonomics, interventions for ergonomics for reduced injuries and illness. And like he showed us a picture of the classic office worker who sits at the computer and they're kind of hunched over. No, you got to sit up, straighten up, proper eye level of the computer, get the hands and the wrists straight. Simple ergonomic fixes often go a long way with these workers, and they just don't realize that they're doing it wrong for long periods of time, and it just leads to this chronic buildup. Then again, let's go back and touch on the skin disorders. We talked about that latex issue. So we talked about the difference between an antigen and an antibody. An antigen is simply just an environmental substance that provokes an immune response, whereas antibody is a substance that is created in the body to help mitigate that response and take care of it. Jumping back to hypersensitivity, the two most important ones that we talked about were type 1 and type 2, and the biggest difference between that is type 1 is being immediate. So like latex would be a type 1 sensitivity where they immediately start getting red or swelling up, or like a bee sting. And then type 4 hypersensitivity would be something along the lines of poison ivy. And I'm severely allergic to poison ivy, and I have a ton of it at my house, and I get it all the time, 3 to 4 days after the fact that I make contact. So that was the biggest thing that we laid down, was this is something that might not present itself right away, and you might not think anything of it until 3 days later when you have a rash on your arm and you're like, where the heck did I get this rash? So knowing that you have that sensitivity, or knowing the things that you're working with, is important. So we kind of touched on those two things. And then we kind of broke those down. That's kind of monotonous and not really all that important going forward, but we definitely need to know it. We just need to know that the sensitivity levels, and then as a PT, why it's important working with those different things with our patient. Then we jumped into the next day, which Josh is going to take over from there.
Yeah, so we talked about like soft tissue injuries, and we're really looking at, we're going down to the basic. We're getting down to the cellular level, which not as interesting for PTs because we're looking at the gross anatomy a lot of the time. But we need to know where we're at from the cellular, what's going on at the cellular level, such as like inflammation through an injury, what's going on, like why is this doing it? So we went backtracking a little bit. We went over a couple of different cellular aging or cellular damage theories. So a couple of them just wear and tear, just over time, tissues get broken down through injuries or just repetitive stress. Another one was free radicals through our body. This was more a little abstract for me because I never actually took
biochemistry, like biochemistry or like microbiology or something along those lines.
So we had talked about free electrons going around in the body and then causing just damage to other tissues around. Then the third was telomere clock aging, which we talked about in our developmental psych class. And it's where like on the telomeres on a chromosome shorten over time. And once they kind of run out of the telomere, that's when you're more susceptible to cancer. That's kind of the theory on that one. So those are the theories on like why our tissues break, or our cells break down, our tissues break down over time. And then we got into an example. The professor talked about his daughter where she had an injury and kind of just like had us talk about what we should do in that situation. Whereas we don't know everything yet, so it was a good practice on what's actually going on. So the girl was running in a meet and had a hip flexor injury where it pulled a piece of the pelvis off the bone.
An avulsion.
Yeah. So it pulled off a piece, and he was like, "What should we do?" Well, us being PTs thought we should start strengthening and start strengthening exercises. Well, he goes, "Well, there's a piece of bone broken off. Is that going to be ready to be strengthened in like 3 or 4 days?" And I'm like, "No, we got to go back because at the cellular level, it's going to take 6 weeks to heal that bone back. So the inflammation is going to occur, and we're going to treat that initially, but we need inflammation to occur post the first 24 hours so that healing can commence. And then we can come in and be the PT and strengthen the muscles, stretch them, get the person back to where they want to be for competing." So really we broke it down from the gross muscle and the bone where we're at, but we had to go all the way back down to the cellular level to really be able to treat that gross anatomy back again. So I think it's really good that we're having this class because I never thought we were going to be talking about cells. I never once thought we were going to be talking about it. Yeah. So exactly, not my forte. So it's a good. I like it. I like being able to put the pieces together because we're treating the whole body, and now that we're direct access, we really need to be knowledgeable about these so that the patient can get the best care possible.
Yeah, that ability to refer and give a decent idea of what might be happening if we do refer out to the right professional, making sure that it goes to the right person.
Yeah, because post injury, that's not our job right there. We got to get it to. He's a PT, and he had to have his daughter go to a doctor to figure out what's going on. So, good real life example, and kind of an eye opener for me anyway.
Yeah, that's good. Yeah, that was a fun class. Our professor in that class is actually an ATC also.
Yeah.
So he's got a lot of experience treating sports injuries and stuff. So it was kind of funny because he said the physician basically made a statement and kind of delivered his diagnosis, and he said, in his head, he said, "Yeah, we'll see about that."
Yeah, because the physician didn't know that he was a PT.
Yeah.
ATC.
So it's just kind of interesting looking at it from that point, and especially being a medical professional, and this was his daughter, And when you're dealing with other medical professionals, you can't be that guy that's like, I'm a PT, hold on,
Exactly.
I got this. You have to be able to listen to them and respect their opinion and then work with that. And if you do or don't have a kind of a differentiation in your thoughts, you can communicate that with them, or you can just roll with it.
Yeah,
And so
awesome.
it's pretty important. That
That
pretty
concludes
much-
it right
that
there.
pretty much covers
A lot
it for
of-
the week.
Talked quite a bit this week,
Yeah,
but
a
there
lot
were
of
some
information.
good experiences that we had, I think, whereas we've been so conceptual up to this point, and then we got to put into practice what we've been learning in lecture. So,
All right, I think that's about all I have to say.
I don't have anything to add
All
either.
right, cool. Well, thanks a lot again for joining us, guys, and hopefully we'll see you next week.
See you next week.